What can I do, Dr. Rec? Dr. Rec said, well, if you just go ahead and break the handle like this and fiddle it around like that, you should be able to get away with it. And unfortunately, there were patient deaths that resulted from that technique. Who got sued? The manufacturer and the surgeon. Dr. Rec went skipping on by down to the next ER. So what happens when novice surgeons learn a new technique and proceed to practice on a human being? Initially, and we'll talk about all of this in depth, there's increased length of the procedure, there's increased cost of equipment, increased operating room time, and then in light of increased operating room time, there's adverse events related to long-term anesthesia, not necessarily just from anesthesia, but also because of pneumoperitoneum, because of patient positioning, and all sorts of other things. And then again, the liability of working with Dr. Rapp. So the patient should look at you like that, in my opinion, and say, so what does this mean for me? And so now lawyers are getting even smarter, and they want the surgeon to be a little bit even more liable. So they say, well, what exactly did your informed consent say? And so not only do you have to include the surgical risk, of course, we all write that down. We all write down bleeding, maximum leak, and all these generic things. And of course, we need to convert to open. I don't think I've ever seen on a form outside of saying possible laparoscopic assistance, we don't include the alternative surgical techniques. And we never tell the patient, we never disclose to them what is our surgical robotic training experience. And the lawyers are winning right now because the patient is trying to say, well, you didn't tell me that you're new to this. You didn't tell me you just took a course last week and you only did 5 of them on a simulator before you decided to do it on me. You didn't give me the choice of figuring out if I wanted to trust you to be one of your 60th one or your 50th one versus your 1,000th. The intraoperative effects of general anesthesia during laparoscopy or robotic-assisted surgery, we're going to call it RAS today. Pneumoperitoneum, of course, has cardiovascular effects, and we'll explain that for those of us who don't know what those are. Trendelenburg position actually has a lot of serious complications. Muscle relaxation, and then cardiovascular effects in turn almost always affect pulmonary compromise as well. So cardiovascular effects, you got mean arterial pressure, which is a product of cardiac output multiplied by systemic vascular resistance. In pneumoperitoneum, you've got an insufflated abdomen. It's putting a lot of pressure on the vasculature on the inside, as well as elevating the diaphragm, increasing a lot of other things we'll talk about. But you increase your SVR, you decrease your cardiac output. Your MAP is still increased, but overall your increase in your SVR is much, much greater than your drop in your cardiac output, which is on the order of 10 to 30%. Usual pressure in the abdomen is 0 to 5 millimeters of mercury. During pneumoperitoneum, it's about 10 to 15. And in our FLS course, Fundamentals Laparoscopic Surgery, there's a nice little test question on that about what's the proper pressure that you want to stay around 12 to 15. But the resistance to flow in arterial vessels due to mechanical and neural factors, because you've got a activation of your renin-angiotensin system, vasopressin, catecholamines. But what do these really do? What do these mean in total? What do they affect? So despite your drop in your cardiac output, you've got increased intracardiac filling pressures, you've got increased pulmonary vascular resistance with decreased cardiac output going to the lung. That is a big deal to a patient with cardiac risk. Okay, and we still don't really know that. We sit up here every Wednesday and we say, well, what did the cardiologist say? What was their risk? Nobody really knows what low intermediate is. Nobody really knows what intermediate, moderate, or severe risk is. But are we really quantifying that to what does that mean for the pneumoperitoneum and the extra stress that adds? I personally don't think that open surgery risk for cardiac patients is not the same as pneumoperitoneum. You may argue and say, well, I can do a minimally invasive thing and it's going to be a smaller incision, it's going to be that, but if I can't do it in 45 minutes and I'm doing it in 10 hours, did the risk really get lower or is the risk much higher? The other issue is intravascular depleted patients are the most risk, and those are the types of patients we deal with on a fairly regular basis in surgery, particularly with trauma patients and even in your elective settings with bowel prep patients. So cardiovascular effects, in order to counteract that and to increase your cardiac output and your venous return, we load them up with IV fluids, and we use vasodilators, opiates, and alpha-2 agonists. Body positioning. We want to get bowel out of our way. We want to move things around and make it easier for us to operate. but extreme Trendelenburg for long periods of time can lead to increased intracranial pressure, increased intraocular pressure, and there have been studies that show that cerebral edema and retinal detachment can occur when you have extended durations of time elapsed. And I remember being on a really long robotic Nissen before, and the anesthesiologist said, she's getting real puffy up here. And the surgeon didn't really say much about it. And I remember thinking to myself, so what? I mean, we're going to be done soon, and when we release the pressure, they'll be fine. But I never really knew that all of these kind of effects could really occur. And that's what the anesthesiologist knew about. This is out of the anesthesia literature. Reverse Trendelenburg reduces venous return and thus decreases your cardiac output and your MAP. Lithotomy has actually an autotransfusion effect with redistribution of blood from the lower extremities to the central body. And then cardiac complications. They always tell you to insufflate slowly. I never knew what the real reason for that was. I thought slow insufflation was to make sure I was in the peritoneal cavity. That's how I was taught by the surgeons that we work with. If you read up on it, if you look at the anesthesia reasons, and this is, again, anesthesia literature, bradyarrhythmias, vagal stimulation are affected when you have a sudden stretching of your peritoneum. You can increase your vagal tone, and you can have bradyarrhythmia even asystole. Pulmonary complications, when you increase the abdominal compartment pressures, even though it's only 10 to 15 millimeters of mercury, you're increasing your diaphragm, you've got increased airway pressure, and you've got decreased thoracopulmonary compliance. You compress the lungs, you're going to decrease your functional residual capacity, which is already decreased because you underwent anesthesia, and it's further decreased in elderly patients. Elderly patients also are at higher risk because the older we get, our minimum end expiratory lung volume, which is required to prevent atelectasis and to keep the alveoli propped open, it's at a lower volume. It increases with age where you have that problem. We still get hypercapnia issues. They rise on induction of the pneumoperitoneum and plateaus for 15 to 30 minutes later, signifying your carbon dioxide equilibrium. Anesthesia does a bunch of surveying of your gases. You can still get a pneumothorax. You can always get a gas embolism if your varus needle goes into a vessel and you insufflate into that vessel. This is a long thing I'm going to read to you, but I promise you it's worth listening to. I don't know which hospital this is, but I want you to hear it. At a major Midwest university hospital, a universally revered mentor of a generation of surgeons, never really progressed in his skills from open abdominal surgery to laparoscopic abdominal surgery. He continued to operate, however, including performing operations laparoscopically. One day, he got into more trouble than he could get out of, and a patient bled to death during a routine gallbladder. The hospital investigated. The investigators found that for 6 years, the clerks who were scheduling the surgery had been routinely ordering extra blood to be set up for possible transfusion during the laparoscopic surgeries because they knew his operations were abnormally bloody. Investigators found that for years, the anesthesia department was actually scheduling their most experienced anesthesiologist in that particular surgeon's room because they knew his surgical risks were greater because of his inexperience. However, no one ever pointed out to that surgeon or to other hospital officials because he was such a revered surgeon. And the reverence that all these observers had for this icon of surgical education was too great for anyone to point out the obvious until a death ensued. So, robotic-assisted surgery. 1990s, again, we thank our vets for experiencing the experimental studies on robotic surgery in the battlefield. Again, remember, in 2000, the US FDA cleared use of widespread Utmc. And then there's been an explosion of it. Between 07 and 10, 80,000 a year to 205 a year. Everybody cites the benefits of 3D magnified vision. Surgeries. They look at the benefits of it. It's 3D magnified vision. It removes tremor from the surgeon. But the most beneficial thing over tremor is actually motion scaling, where you have magnification on your screen that actually increases your accuracy. Improved manual dexterity, enhanced ergonomics. These are all things that surgeons would love to embrace because as we get older as surgeons, we've got back problems. We have vision problems. We have cognition problems. We have tremors. I mean, these are all things that allow us to increase our lifetime of being a surgeon. And then patient potential advantages. Decreased length of stay, improved recovery time, decreased post-op pain, decreased estimated blood loss. There's no consistent consensus by a single professional organization about what the credentialing process should be for robotic surgery. Currently, only individual hospitals create their own standards. There's not a national consensus at all. There's no national database by a surgery group or some type of professional organization for this. It's all driven by the manufacturer. So right now, the database that exists is a manufacturer and user facility device experience, and we're going to call it MOD. So they look at device-related injuries, the limitations that you cannot reliably use it to evaluate adverse outcome rates. The valid data on complication rates and adverse patient events is limited, lacking, or conflicting. And then there's no study exists to support that robotic is actually conducted by experienced robotic surgeons that has complication rates that differ from other techniques. So there's a couple of groups that have used MOD and kind of thought about all these other topics that we've already talked about, but they're all urologists and gynecologists and quality measure groups. We'll see that in a second. So Gupta looked at adverse events associated with the Da Vinci system in the FDA MOD base. They just quantified these injuries by specialty. The highest injury group were the GYNs. I think it's kind of preposterous and speaks to the limitations that you have a non-specified group, but they comprise 29%. You can't even tell us who those 29% of people are. Urologists comprise 27%, and then there's the other, again, who is other? 10% is actually a pretty big number. These injuries were associated with 43.4% involving energy instruments. 44% is a huge number. Imagine using an energy instrument incorrectly during an open procedure. And if you use the energy instrument incorrectly, sometimes you end up having to do bowel resections because you don't want to compromise the bowel in the future. All those things add possible morbidity to your procedure. You've got 19.3% due to the actual surgical system and 11.7% as an instrument and accessory. Cooper acknowledges that there's underreporting of the robotic complications in the Health Quality Journal. So it's difficult to separate poor surgical skill from device-related injuries. There's little oversight regarding the reporting, and there's little incentive to improve reporting. In 2007, the Society of American GI and Endoscopic Surgeons with the MIS Robotic Surgeons Association thought that these topics should be a part of training. Didactic training, live case observation of an experienced robotic surgeon, simulation training, and preparation for a mentored clinical experience at a hospital. So what do we know so far? We have basic training, but we know it doesn't ensure our surgeon competence. We know that the learning curve is steep, like Dr. Jamil pointed out earlier today, and that it's also individual dependent, and it's very costly to train. The steep learning curve, how does that translate? Davis looked at learning curve assessment of robot-assisted radical prostatectomy, again, urology, compared with open surgery controls from the premier prospective database. Between 2004 and 2010, they looked at 70,000+ reports at over 300 hospitals by 3,700 surgeons and only looking at their results within 100 cases. So each surgeon had to have done 100 cases robotically, specifically this procedure, the radical prostatectomy. The key variables they looked at was conversion to open, surgical time, length of hospital stay, complication rate. The conversion to open showed after 100 cases an improved conversion rate from 1.1% of the time to 0.31% of the time. Their surgical time decreased from 5 hours to 4 hours. Length of hospital stay decreased from 2.4 days to 2 days, and their complication rates decreased from 11.75% to 8.93%. The robotic systems cost, like Dr. Zelnock said today, millions of dollars, on the order of 1.5 to 2 million for each system. It's costly to train a surgeon. It takes about $10,000 per surgeon in order to make them an experienced robotic surgeon. Steinberg looked at the cost of learning robotic-assisted prostatectomy, thank you, urology, purports a theoretical model to determine operation costs during the learning curve. They said that 360 cases with operative and anesthesia costs totals 1.3 million. And remember, it takes you 100 cases to really show any significant effect. I came across this site, and this site is wonderful. It's the Pennsylvania Patient Safety Advisory site. And they go through everything that happened in Pennsylvania and what they think, and Pennsylvania is leading the force right now, in my opinion. But since 2005, they've reported 722 safety events. 75% of those incidents resulted in no patient harm, but about 25% of them were serious events. 98% of those serious events were related to the actual procedure technique. And then 10% of those patients died. The event type, 44% of the time was related to unintended laceration or puncture. I'm gonna just let that resonate for a bit. Unintended laceration or puncture, 44% of the time, that's a huge number. That should never be acceptable, I think, even for something more than 1% of the time. Bleeding, 18%. Patient positioning, 20%. Some benign thing that we really don't stop and think about. Retained foreign body, 4%. Infection, 4%. So what stops are in place? What happens? What does credentialing do? This is our resident experience. You know, every single step of the way, there's somebody in your face. What are you doing? Stop that. No, did you do that? What do you know about that? How do you do this? When you become attending, life is beautiful. There's beautiful roses. There's a lovely, everything smells great. No matter what you do, you know, yes, that was an acceptable thing. You understand, that was such a, we can see how they got to that complication.
I can prove it. That's not
I'll go ahead and put myself in there. I'm the guy on the floor. So, you know, over here at UT, we have the Mimic. And, you know, UT is a part of leading the force. I will give them credit. The Mimic has been used around the country. It's being pushed as something that's really good for residents as well as surgeons to use. So, about to give Dr. Nazal a really good reason to pressure us to go over to the simulation center. So they looked at 3 groups of 14 OB-GYNs. They all did supracervical hysterectomy. They had 3 groups, the control group, the expert laparoscopy OB-GYNs, and then the novice OB-GYNs trained by expert robotic surgeons. And they found that your operating time decreased by 32% just by using the Mimic. You had a decreased EVL, decreased costs, less complications, all when compounded with proctoring by expert level OB-GYNs. Resident is a study that shows that 10 surgical residents trained on the robot up to proficiency standard with inanimate models, which is a dry lab or simulation. And they looked at them at 2, 4, and 6 weeks for 1 hour each time. Each resident performed a timed tissue closure task immediately after achieving proficiency standards, and then again twice at 8 weeks. All residents had a decreased task time by 25%, and they concluded that biweekly practice was sufficient to maintain robotic proficiency standards. What is the policy here at UT? I called the credentialing office and actually spoke with the lady who's in charge of that. There's an intuitive surgical course that's required. It's just a 1-day course. It's in various cities, not accessible everywhere. It's basically a 1-day thing that goes over the actual machine, how do you use the machine, how do you dock the ports. It goes over how the machine works. It goes over didactic training, and you do a dry simulation. Then the surgeon is required to go through 2 to 3 proctored surgeries on real patients that are non-surgery specific. So that means that I could do 2 to 3 robotic inguinal hernias or robotic cholecystectomy, but I don't have to do a Nissen fundoplication robotically, but I can, after I've done the 2 to 3, I can go ahead and do a Nissen robotically. There's no specific number of robotic surgeries that is defined, that defines a proctor surgeon here at UT. And there's no continued recertification. Again, it's not a knock on UT. It's an example of how, because we don't have a national standard, that our hospital is also just like the rest of the country in the beginning stages of trying to figure out what is our policy going to be on credentialing. So what are the other hospitals doing? There are several of them. I looked at one at UC Irvine. Their process is like over a 5-day period. I picked the best one in my humble, naive, amateur surgeon opinion. And Tacoma General Hospital was really, really good. And so Lenahan looked at navigating credentialing, privileging, and learning curves in robotics with an evidence and experience-based model. And this, again, thanks to the GYNs. They looked at an aviation model. What is an aviation model? Aviation model is when you do the dry lab, you do the simulation, you get tested. If you fail that, you got to go back and get retested to achieve proficiency. You get proctored, and then you get evaluated throughout. You continuously get evaluated. Every single year you take a test. If you fail, you have to be remediated. So they used that model and applied it to medicine. And they're calling the surgeons here, they're calling the OB-GYN surgeons. So identify training surgeons who perform major surgery, are comfortable with complex surgical procedures, and have laparoscopic experience. The components of their program, again, is very reflective of what the GI Endoscopic and Robotic Association is talking about as far as using didactic training, dry lab, and case observation. But they added, as well as proctor, but they added live animal models lab training. They gave consistent training to all of them, each with a minimum of 2 proctored cases and mentored by a skilled robotic surgeon when performing complex or new cases. So that means they couldn't just do 2 to 3 and then do another type of surgery. Every time they did a new case or a complex case, they had to go back to that mentor that was identified as their mentor robotic surgeon. They define their proctor. Their proctor is defined as somebody who does greater than 40 robotic surgeries internally or externally. This proctor has done the procedure that is being proctored, and the proctor has to have passed a standardized evaluation process that is reported to the surgeon and the executive team at the hospital administration level. They require them to do 12 to 15 simple cases before attempting complex cases, and then after the training, the surgeon starts doing human cases right away. There's no delay in anything greater than 60 days after their completion of their training. And they have a peer review committee. So there's a focus review of the first 5 basic cases and the first 3 advanced cases. The established minimum is 20 to 24 cases a year, and at least 1 case they have to do every 8 weeks. If the surgeon fails to meet that quota, they give them the option of trying to increase their volume, and if they're unable to do that, then they have to go back and start over again. So they have to retrain in a dry lab, the next 3 cases are proctored, etc. So in closing, again, I'm stressing personal responsibility as technology influences the way we practice, influences the way we train, influences the way we talk to our patients and operate. And in keeping with the Hippocratic Oath, do no harm. I want to encourage national implementation of proctoring of surgeons by expert surgeons prior to starting a new procedure, and then reporting. X number of complications that mandate addressing in the form of remediation or suspension of surgical privileges, and possibly making that team up of either anesthesiology, surgery, and quality measures. Thank you. Thank you.
The last point in the presentation. Well, if you implement that, surgeons are going to avoid taking high-risk patients. Who's going to take care of those patients?
What do you mean by avoid high-risk patients?
If you are going to remediate me or suspend my privileges, if I get a certain number of complications, I will only take patients who are straightforward, simple procedures, and any high-risk patient, I will defer.
So how can you defer a dying patient, or how can you defer a patient that nobody wants to operate on? I mean, this is just going back to knowing that you're going to operate on. There's never a surgeon that just defers all of their sick patients. They eventually have to take on a sick patient, whether it's in the middle of the night, whether it's something that you have to do in the next 24 hours, and you can't transfer them someplace because they won't accept them. So
there's some efforts where people do that now with open surgery. There's no doubt there's some shifting of high-risk patients to certain centers or certain surgeons. So it can be done, and you can also risk adjust the patients based on comorbidities and technical things. I think this is really helpful, Candice. Just yesterday, I signed from one of our surgeons to have robotic privileges, and it made me a little uneasy because there's only 2 proctored cases. We, that is the profession, are going to have to decide what other criteria, and maybe diplomas will be adopted or some modification, rather than the intuitive surgical company deciding what can happen. I believe it's the case that there are 17 robots in the Toledo area. That's utterly absurd. And if anybody can show clinical or financial benefit to robotic surgery, despite its wonderful potential, I'd love to see the paper. I've challenged the intuitive reps to give me any data to show better clinical outcomes or financial break even. And so far, it hasn't happened. And yet, robotic surgery has tremendous potential. We as a profession need to do exactly what Candice said, take this personal responsibility for things. And I can tell you, you watch Tiger Woods, he practices 1,000-fold for every round of golf that he plays. You watch a professional athlete, they go to batting practice. You watch how pilots do what they do, they're in simulators all the time. This is part of our world, and the technology has gotten so incredibly complex. I think you're now going to be certified in each procedure you do rather than just a broad board certification for neurosurgery, orthopedics, general surgery. You're going to be certified for each procedure, and the databases are so robust that they're going to tell you, right now the insurance companies can tell you exactly what Dr. Locke's anesthesia time is, what his blood loss is, and how that compares with Dr. Height, and so on. They have this data. We will soon have it to feed to people in a hopefully constructive way. And probably some of us will experience restriction of our privileges over time, but it has to be done the right way, risk adjusted, and so on. But it's a really complicated world we're entering into because the technology changes, and it's accelerating how fast it's changing.
But to also Osmond's point too, I think that patients are going to demand that they get this minimally invasive, and you have to be on point with that in order to get your RVUs and things like that. If you're going to be a general surgeon and not doing lumps and bumps, if you want to keep up and make money and support yourself, you're going to have to do it.
But it's not only really robotic. We keep talking about robotic because it's expensive.
Right.
But thinking about endovascular,
that's right.
The same. Carotid stenting, the first guy in the United States who pushed carotid stenting, he was hiding his results. The same data that were analyzed by a statistician a year ago, the stroke rate, he claimed it is 2%. But when they went to the stroke rate, actually by the statistician, it was 12.3%, the same data. So it is all of it, actually. I don't think we will win. We have to, the hospital has to make money. Last comment, then
first of all, I think it's a really good presentation, Candice. The sales representative, because of all the technology and the way it's changing, the sales representative is hard to train the team. And you have to keep it in perspective. Our responsibility is going to be to have material for you and mentoring for you that will tell you what to do when your default position is to open the patient. You have to be faster with that. The second thing I think is going to happen very quickly, if it doesn't happen by mandate, is that we're going to change our vocabulary. Because the concept of minimal number of cases for advanced technology is a real problem. And to say that the peer review system within a particular organization has suspended your privileges has far-reaching downstream ramifications. So it'll have to be a different set of vocabulary that we have, so that you are voluntarily on hold because of the fact that you go back into the sim side.
well, thank you very much. There's a lot to say about this topic, actually. Unfortunately, we will never cover it. But for the sake of time, our fourth resident for the year, Venkat, he came to us from Russ University, Grenada. Then he went to another city, or sister city, if you can call it, in the east part of the state, without mentioning the name. Then he came after that for fourth and the fifth year. He is interested in vascular surgery, and he is already matched in Long Island Jewish Hospital, New York, for vascular surgery. He will talk, as expected, about abdominal aortic aneurysm.
Good morning, everyone. Today I'll be talking about abdominal aortic aneurysm. Initially, I thought I was going to present arterial aneurysms, but doing the presentation, I realized just an hour we can talk about abdominal aortic aneurysm. So I condensed it to AAA, and then I'll try to be in the time limit of 20 minutes. So what are the learning objectives for what AAA is? Basically understand the epidemiology and the pathogenesis of the AAA. Try to be familiar with the appropriate diagnostic measures. You understand the role of screening for AAA, and recognize indications for referral and repair of AAA, and be familiar with available surgical options. So starting first, how do you define a AAA? Aneurysm is basically if you have defined as a permanent focal dilatation that exceeds 1.5 times the normal expected diameter. So in normal adults, the size of the aorta is 1.5 to 2 centimeter range. So if you have a aorta size of 3 centimeters, you can consider it as an aneurysm. There's the definition of ectasia, which is basically it is a diffuse dilatation of an artery with increase in diameter, but it's less than 50%. And then arteriomegaly, which is a diffuse non-focal enlargement of several arterial segments with increase in diameter greater than 50% of the normal expected diameter. So you can have aneurysm within an arteriomegaly. Also we need to understand how you define the different types of AAAs based on how the aneurysm extends caudally. You define the infrarenal. Almost 80 to 90% of the aneurysms you see are infrarenal aneurysms, where it doesn't go close to the renal artery. You have at least 1 centimeter length, which is normal aorta. If it's involved, it's not involving the renal arteries, but it's close to the renal arteries. You call it just a renal aneurysm. And if it's involving the renal arteries and extending beyond the SMA or the celiac, you call it the suprarenal. And if it's going into the thoracic aorta, it's called the thoracoabdominal. So what are the pathogenesis for developing AAA? As age increases, we all know that arteries become stiffer, wider, and longer. It involves a multifactorial systemic process. Most common are the two common things are the structural weakness and the hemodynamic forces. First, structural weakness, you can have inflammatory changes to the intima, which can lead to the initial weakening. There are other enzymes, proteases, and macrophage elastase, MMPs, which can reduce the elastin in the media, and also the collagenase can reduce the collagen content of the media. And then because of the decrease in collagen, it can have decreased tensile strength, and that adventure is affected, and that will lead to a true aneurysm. So what are some of the risk factors for abdominal aortic aneurysms? Any patient above 60 years of age, they tend to develop a high risk factor for developing AAA. Smoking is one of the strongest independent risk factor for AAA, and also active smoking is associated with the highest risk of aneurysm progression and rupture. Hypertension is also increased risk for developing AAA, approximately 30 to 40%. And I used to think that systolic hypertension would be the highest risk factor, but they found that for all the cardiovascular diseases, diastolic hypertension was found to have the highest incidence or developing AAA and expanding rates of the AAA. There's a genetic and familial trend. Patients who has a primary relative with a AAA, approximately 18% of these people have incidence of AAA. Also, connective tissue disorders like Marfan's and Ehlers-Danlos syndromes, they tend to develop AAA, but most commonly they involve the thoracoabdominal rather than just the abdominal aspect. There are other aneurysms, the popliteal and femoral, which I briefly described, and then atherosclerosis. Negative risk factors for developing is diabetes. Actually, was found, and moderate alcohol consumption was found to decrease the risk of developing AAA. And then female gender also has decreased risk for developing AAA. So, as usual, if you have an aortic aneurysm, there are other relationship between aortic aneurysm and other aneurysms. Patients who have iliac aneurysm, they tend to approximately 40 to 80% of these patients tend to have a 50% of these patients tend to have abdominal aortic aneurysms, but it's kind of reverse. With the patient who has AAA, there's less than 5% of these patients tend to have a femoral or a popliteal aneurysm. And patients with carotid stenosis, 10% of them have AAA. So basic point of this slide is to make sure that you have a femoral popliteal aneurysm or carotid stenosis. Do look for screen for a AAA. So epidemiology, usually age between 70 to 75 years, a reported incidence of 5 to 7% in the general population. Males are more prone to develop AAA compared to the females, and white Caucasians are more prone than African Americans. Mortality, morbidity grows about 4.4 centimeters per year. Upon rupture, usually say 50 to 75% mortality, and it's the 13th leading cause of death in the U.S., approximately 15,000 deaths per year. And overall mortality is 0.95% after repair. And as we all know, rupture of the aneurysm is based on the size, which I'll discuss in more detail. There's an increasing incidence of AAA. This study was from England. They showed that almost from 1981 to 2000, they showed that the mortality rate has considerably increased 3 times. And then hospital admissions for both elective and emergency admissions also considerably increased within the general population. So what are the symptoms and signs? Most are asymptomatic. They're disclosed on routine screening or routine physical exam or imaging studies. Inflammatory AAA may cause back pain that you need to examine. Pulsatile abdominal mass is usually very rarely feel that, but most common location is in the mid-abdomen, just above and left of the umbilicus. And then a ruptured AAA is that reduced, I mean, the person doesn't survive. And then I found this pretty impressive that almost patients who come in with a ruptured AAA, 30% of them are misdiagnosed. Initially, there was about 40 to 45% were diagnosed, but even with the new recent CAT scans and everything, still the rate of misdiagnosis was 30%. And based on where the rupture is, you can have different physical exam findings. So if you have a rupture in the proximal aorta near the renal arteries, tends to lead to severe back or flank pain. And if there's a distal rupture near the iliac bifurcation, you can have a low abdominal pelvic pain that may radiate to the groin or thigh because it irritates the lumbar nerves. Posterior aortic wall rupture is basically one which patients can survive better compared to the anterior aortic wall. The reason being because once you perforate into the retroperitoneum, it will provide some kind of hemostasis compared to the anterior aortic wall where a free rupture, it can, initial manifestation will be just abdominal pain, but it's going to progress much more quickly compared to a posterior aortic wall, and then patients usually doesn't survive the anterior wall rupture. Patients also can present with limb ischemia. AAA can present initially with symptoms of lower extremity ischemia due to the travel of the ambulance traveling into the lower extremities, and in association with abdominal, back, flank pain, and distal emboli, you can highly suspect that as a sign of an aneurysm rupture. You can have develop ecchymosis, which is the great donor signs where you can see the ecchymosis in flanks and the back. So what are some of the imaging modalities to diagnose AAA? First is X-ray. I found that almost 70% you can see a large AAA aneurysm. You can see this calcification here. Best modality is screening modalities for ultrasound, CT, and then arteriogram. So physical exam, if you palpate a firm pulsatile abdominal mass, the oral sensitivity for physical exam diagnosing a AAA is very low, but the sensitivity increases with diameter. So if you have an aneurysm greater than 5 centimeters, they found that the sensitivity is about 76%, but iliac artery extension is not appreciated on a physical exam. X-ray, I found that some of the textbooks said that about 70% of cases can diagnose the X-ray, you can see it. So characteristic is the eggshell pattern of calcification, but the X-ray, the limiting point for X-ray is it can accurately determine the size of the aneurysm. Ultrasound, it's the most widely used non-invasive test, and it provides structural detail of the vessel, and it can measure both longitudinal and cross-sectional area. And its advantages are it's non-invasive, low cost, it's widely available, and good initial evaluations for patient screening and surveillance. But the best modality is the CT. It can identify the proximal and distal extent of the aneurysm. You can see if there's a thoracic extension too, and you can see if there's a presence of multiple or accessory renal arteries, which will help her during the open repair or during the EVAR. And also, it accurately assesses the size of the aortic lumen if there's presence of thrombus and presence of calcific disease in the iliacs. Or the amount of thrombus will help us during the EVAR technique, because if you have thrombus, it's going to be hard for the proximal graft to be nicely adhesed to the wall. So you need to know whether there's thrombus or not. So CT would be that's the reason why it's best modality. And also, you can also do MRI. MRI is reserved for patients who has renal insufficiency or can't give them contrast dye. It's a very good modality to have high quality images of the aorta. And then arteriography is also can be used, but due to the thrombus, sometimes the aortic lumen is normal in size, so you can't really get an accurate assessment of the size of the aortic lumen. So it's not a straightforward technique. So screening is very important for aneurysms. I always ask you questions. So they did 4 randomized trials of screening has been performed, and they found that doing this has reduced the mortality quite a bit from 21% to 68%, depending on what study it is. Most published study was the multicentric aneurysm screening study from Europe. They screened about 70,000 men between the ages of 65 to 74, and so they referred any patient above 5.5 centimeters aneurysm for a repair, and after 40 years, they found that this % reduction in AAA-related deaths in the screen group. Also, Society of Vascular Surgery US also have screening recommendations. They suggested that baseline ultrasound screening for AAA in men 60 to 85 years of age. For women, it's between 60 to 85 only with cardiovascular risk factors, but not in general women. Men and women older than 50 with a family history of AAA was also said that they need to be screened. For a patient who has a 4 to 4.5 centimeter aneurysm, best modality is to do an ultrasound, yearly ultrasound. And if it's greater than 4.5 centimeters, they suggested that it should be done every 6 months. Other groups have other recommendations, but the United States Preventive Task Force 2014, they recommended that for screening in men between 65 to 75 years of age who have ever smoked, they recommended selective screening men who between 65 to 75 years who has never smoked, patients who have risk factors. But women, they recommend against screening as current evidence is insufficient. So for women, they don't have any recommendations, but for men, they suggested that 65 to 75 who ever smoked, you have to do a screening. So complication of having AAA and how does it expand and rupture. Average growth rate is approximately 0.4 centimeters per year. What are the factors involved in the growth rate are blood pressure, size at the time of the detection, and COPD. And then, as I mentioned earlier, diastolic blood pressure is also correspond to increase the size of growth rate and rupture, and also smoking, current smoking. So size is the best treatment for rupture. The study showed published in JAMA rupture rate. They said that patients who are not treated with greater than 5.5 centimeter then you already know the Laplace law where tension is proportionally related to the pressure in the radius. So increase in radius, there's a proportional increase of the tension on the aneurysm and leading to rupture. So this is a graph which shows that a patient who has 5 to 6 centimeter aneurysm, the risk of rupture per year is about 7%. If it's greater than 7 centimeters, it's about 20%. So within a year, there's 20% chance that the patient can rupture. So it's very high. So this is a picture of ruptured AAA, where it's free extravasation of blood into the retroperitoneum. So there's a Joint Council for the American Association of Vascular Surgery. They came up with 10 points on how to diagnose, screen, and treat patients. They said that there's no single threshold diameter for elective AAA repair that is applicable to all patients, and the decision for repair must be individualized in each case. And then randomized trials have shown that the risk of rupture less than 5 centimeters is quite low, and the policy of careful surveillance up to diameter of 5.5 centimeters is safe, unless there is a rapid expansion greater than 1 centimeter per year or patients that develop symptoms. However, early surgery is comparable to surveillance with later surgery, so patient preference is important, especially with patients who have between 4.5 to 5.5 centimeters. So based on this current evidence and trials, they found that the diameter of 5.5 centimeters appears to be the appropriate threshold for repair in an average patient. But patients who are younger or low-risk patients with long projected life expectancy may prefer an early repair. And they also mentioned that if the surgeon's personal documented operating mortality rate is low, then repair may be indicated at smaller size between 4.5 to 5.5 centimeters, and only if the patient prefers it. And there's other recommendations. I'm not going to go through all of them. But, so what are the treatment options? So any aneurysm less than 5 centimeters you can observe. And then there are two options. We offer patients as open surgical repair versus endovascular repair. Open repair is synthetic graft. Currently, right now, 30% of the cases for AAA repair are done open. I'm sure it has changed quite a bit now, or still about 30%. Differs on individuals. It's primarily open surgeries for poor anatomy, and occasionally they use it when the patient is young because better results long term. Endovascular repairs, they use 70% of the current cases are done endovascular. These preferred for patients who are unfit for surgical repair, or patients who have severe cardiopulmonary diseases, or partial kidneys, or inflammatory AAA, or patients who have previous multiple abdominal surgeries and a hostile abdomen to get into them. So what are the anatomic requirements for EVAR? The length, angulation, and diameter of the infrarenal neck. So if the angulation should be less than 60 degrees, if it's greater than 60 degrees angulation, they found that there's a 70% complication rate in terms of developing endoleaks. The minimum adequate length of the renal from the renal artery should be at least 8 millimeters with the new grafts, but desirable length is approximately 1.5 centimeters so that the proximal edge of the graft can lay below the renals. The iliac artery diameter should be at least 7 millimeters so that you can accommodate the device, and small enough to allow the device to seal, so it should be less than 1.5 centimeters. If there is concurrent common or internal iliac artery aneurysm, it might pose a difficulty to place an endovascular stent, but nowadays with the new technologies and new stents, they're able to even do that without anything. And then the key point is you have to make sure there's no amps, no thrombus at the aortic neck, because if there is a thrombus, it does not allow for a good neck seal. So this is an operative repair technique. I'm not going to go into full details, but you do a complete arteriotomy. You can use a tube graft or a branch graft, depending on where the aneurysm ends. And then you close this is the left renal vein. You can sacrifice the left renal vein in situations where you can get good control. Also, some questions they ask you also have to watch out retro aortic renal aorta, we thought properly isolating the renal vein or identifying it, you can clamp it and you can get into severe bleeding and possibly death. So this is an open picture. You can see this is an aneurysm wall, and then this is a branch graft. So what are the complications for open repair? It's mortality has decreased quite a bit from as time progresses. Most frequent cause of death, they allow us to ask you that question, is ischemic myocardial injury. Complications, most frequent complication is a non-fatal MI, which is approximately 7%, and it happens usually within the first 48 hours post-operatively. You develop renal failure, post-renal failure. Patients who develop post-renal failure after surgery, they found that approximately 30% mortality rate. And they also can develop pneumonia because of being in the hospital with a long period of time intubated and things like that. You have other complications, ischemia of the left colon and rectum, phobia or abscess question to always. And they can develop ADS, and they also can develop DVT and post-sexual dysfunction from injury to autonomic nerves during dissection up to 25%. Late complications after successful repair, elective open repair are pretty rare. It only occurs about 10% of patients, but the most common complications are anastomotic pseudoaneurysm, develop graft thrombosis, or 1% graft infection. This is a picture of the endovascular repair. This is the graft device, which is below the renal, and then there's a gate for you to place the stent in the contralateral aneurysm. So what are the potential drawbacks for EVAR? You need frequent CT scans follow-up every month after, first month after the initial procedure, and then at 3 months and 6 months, and also every 1 year and every year thereafter. They're 90% efficacious at 6-year mark. The need for conversion and late rupture rate are pretty high, and up to 25% of patients need reintervention within the first year. This is a slide which describes the types of ankle leaks depending on. So type 1 is where there is a lack of complete seal between the stent graft and the vessel wall at the attachment site. So that's why it's very important to make sure there's no thrombus at this area, and also the aorta has to be less than 36 millimeter size. Type 2 is backfilling of the aneurysm via either you have the lumbar or the inferior mesenteric artery, which can branch. And type 3 is leaks at the connections of the modular component. This is a modular component which we attach to the gate, and this can leak, and they can develop increased aneurysm size. And type 4 is basically extravasation of the blood through the graft course. So usually type 1 and type 3, the ones we go back and fix them. Open versus EVAR, there's 4 different studies comparing the open technique versus endovascular study. So Mayo Clinic followed up 307 patients and followed up to 36 years. And the 30-day mortality was about 5%. And then Canadian AAA, they observed 680 patients followed up 6 years, and the 30-day mortality was about 5.4%. But the EVAR trials, there's large population size. It was done in the late 90s and followed up only after 4 years. But the 30-day mortality was only about 2% in both trials. As a usual for a rupture repair, EVAR is superior. As I said, 30-day mortality for EVAR is about 19%. Even for a rupture one and open is about 47%. And the length of stay is 6 days versus 18 days. And patients who had rupture repair had EVAR, 55% of them went home versus 20% of the patients. And OR time is EVAR is 3 hours and 4.5 hours. So the DREAM trial was the one which first randomized patients comparing the open versus AAA. For open versus EVAR, they found that the 30-day mortality was better in the EVAR group compared to the open group, and also showed less operative mortality and post-op complications. And then there were two other different trials, EVAR-1 and EVAR-2 trial. The EVAR-2 trial looked at the effectiveness of EVAR in high-risk patients, which are not amenable for open repair, and they compared just doing the EVAR to observation, and they found that there's no benefit for EVAR over observation. And, both mortality rates were about 9%. And then the US trial, Veterans Affairs trial, they randomized a multi-center trial of 881 veterans, where they compared for both elective endovascular repair and open repair, AAA repair. They found that the endovascular repair group had reduced median procedure time. They found that it has low blood loss, transfusion requirements were low, and the duration of mechanical ventilation hospital stays. They all found to be better than compared to an open. But there were no differences between the two groups in the major morbidity, procedure failure, or secondary therapeutic procedures. So they found that the trial demonstrated lower 30-day mortality when compared to the open repair. So last slide, where are we going next? One of the limiting factors for EVAR was involving the renal arteries, but now with the new fenestrated branch grafts and chimney grafts, they have been able to do these without much morbidity. So it's interesting, and the new stent grafts, the way they're treating this disease. In the future, most likely, the real world for open cases will be less than 30%. Will be, I would say, everybody will be doing endovascular.
Any questions? Can you talk a little bit about the EVAR-2 trial? It looked like it was showing that you should not treat them at 4 years. Just medical management was the same as having EVAR. When you expect them all to rupture by then?
Yeah, I mean, only patients who are high risk for open surgery, they compared it with just watching them, observing them for a couple of years versus doing EVAR, and they found that there's no difference. So even if you operate on a patient with high risk, their risk of mortality is high, so they suggested that it's better to observe compared to EVAR.
These are all patients that normally, if they were healthy, we would operate on because in that operative. No, they are too high risk.
Yeah, high risk ones. Which are not.
I have a question. So you said like the most frequent complication was the non-fail MIs. Has there been any studies about what is it about that procedure or maybe the patient that can be done to change or decrease that morbidity?
I'm not aware of there's any studies done, but patients who have AAAs, they already have a risk of atherosclerosis and coronary artery disease. So that's one of the primary reasons why they are prone to more MIs than other morbid conditions.
Okay, thank you very much.
We are done with the conference. Just meet the residents with the mic.
So we have to work here a little bit. There's a journal, the Journal of the Humanities, but it's almost a half-based type of issue. Okay. I think it could have been written up as a. Sure, I would love to do that.
Yes, sir.
Well, you were out when you're
It's just a detailed topic.
as well. Probably written up
Is that yours?
opinion piece for.
Maybe
I would love
Candice.
to see that.
Are you meeting with us?
I would love to.
Okay.
In fact, it is a big deal. How do we credential people properly? How do we
I actually really liked Candice's talk. I thought it was very. I thought even just how you spoke was so.
I'm very passionate about it.
The residents have a seat, Muhammad. What's going on?
Did anybody else notice that they did the first hysterectomy before they developed anesthesia?
A lot of things were done before anesthesia. Communication before anesthesia.
Yeah, a lot of stuff.
A lot of things were before anesthesia. So that you can go quick. We talked about research last time. Two things. The groups. Did we decide? Everybody know who's his group and who's in charge of that group? Do we know that? Yeah. Okay. So the two chiefs, please decide. And usually you need different levels of strength and no weaknesses, just different levels of strength. And give their names to Mary. The other thing, research. We need to talk about two different types of research. The quality outcome research, which we can do here. We're not talking about basic science here because none of us are going to go to the lab now. But quality outcome, and the other one, education. Any of you, any idea, what is a problem in education or something related to education or outcome related to education? Any idea, even if you think it's too stupid, please write it. So we can start one or two projects for next year. Very important. Yes, sir.
We're in the middle of one, meaning still with the simulation for the.
No, these are different. I'm talking. These are the three last year. I know about them. I'm talking about new ones. So whatever we did 3 projects last year. They should be come to a conclusion next month to write them up and submit. We have to. But I'm talking about the new projects. The projects we did was the simulation.